Hello, my name is Bruce Feldman, and it's a privilege to share some important thoughts with you about the STEMI Alert process and the activation of this process for patients with possible or definite acute coronary syndromes prior to patient arrival in our hospital. My background as a clinical cardiologist has included the involvement of evaluating the process of care since 1996, and I've been fortunate to work with a team of people at Lehigh Valley Health Network to create a very successful program designed to rapidly recognize this true cardiac emergency of an acute myocardial infarction and to offer a process of care that establishes the diagnosis and establishes options for reperfusion in a timely fashion. To give perspective to this problem, it's important to review the basic pathophysiology of the process. We believe that all of the acute coronary syndromes, commonly referred to as ACS, are mediated by thrombus formation in a diseased coronary artery. This is a photomicrograph of a disrupted coronary vessel wall leading to formation of thrombus in the lumen of the vessel. If the thrombus is large and occludes the vessel, the delivery of oxygen and nutrients to the myocardium is impaired, and this is what results in the symptoms, EKG changes, and myocardial necrosis that subsequently ensues. Thrombus formation, we believe, is the mediator for both the ST elevation type myocardial infarction, so-called STEMI, as well as the other forms of acute coronary syndromes in which the EKG pattern does not show ST elevation, so-called non-ST elevation myocardial infarction, and in patients who have normal EKGs but the symptom is present, what we refer to as unstable angina, ACS. This clinical syndrome is a true cardiac emergency that leads to death in a significant percentage of patients. Just as a review for you to appreciate the mortality rates in these patients is this bar graph. If you bring your attention to the dark bars, which reflect the 30-day risk standardized mortality rates throughout hospitals in our country from 1995, you'll see that on average 18 to 20% of people die from this syndrome. There's a wide distribution of mortality rates extending in the worst case scenarios up to 25% mortality, and in hospitals that provide perhaps good care or deal with lower risk patients, mortality rates in the range of 10 or 12%. There was a great effort in the cardiology community to improve the prognosis of patients over the ensuing 10 years from 1995 to 2006, and you can see the lighter bar graph reflecting the improved mortality rates, but still, on average, 15% 30-day mortality rates are observed in hospitals throughout our country. And one of the important questions that's generated by this type of data and bar graph is, why is it that some hospitals are observing patients with mortality rates that are in the low range, 10% or so, versus the high range, 20%, a very big difference. One of the theories that accounts for this difference is time to treatment. This graph demonstrates the impact of symptom onset to treatment time. And you can see plotted in red, which is the average time since symptom onset, relative to 1-year mortality rate among a patient population of approximately 1,800 patients with ST elevation myocardial infarction. As the hours go by before treatment is initiated, the mortality rate increases. And one of the insights from this graph is to appreciate that the symptoms actually begin prior to patient arrival. And many patients may not initially respond to their unexplained symptom of chest distress with urgency or concern. And there's often a significant delay before they seek medical care and contact either 911 or bring themselves to a local emergency room. In this hypothetical scenario, we've created a dotted line at the 60-minute mark representing the time from onset of symptom to contacting medical care. And then there's an additional time delay between contacting medical care and when they actually receive appropriate reperfusion therapy. And again, in this hypothetical example, you can see that the total time is significantly influenced in part by those two time windows, prior to hospital arrival and subsequent hospital arrival. And processes of care built into hospital systems to reduce diagnostic time and therapeutic time are very important, but so are the strategies of care to reduce time from symptom onset to initial contact, very helpful in minimizing long-term mortality. We recognize that all the emergency medical systems in our community are our partner to help us with the pre-hospital phase of recognition of the cardiac emergency and its initial management. And the focus of our discussion is going to be on the pre-hospital process of care before patient arrival. Just to exemplify the value of recognizing the syndrome of acute MI and activating the process of care prior to patient arrival, let me share some data collected in 2010. You'll see plotted is the pre-hospital MI alert process among 135 patients in whom the activation occurred prior to patient arrival, relative to patients who presented themselves or with their family's help to our emergency room. Among 135 patients, the percent of them with a door-to-balloon time less than 90 minutes was 96%. Almost all the patients received timely care. In contrast, when they present to the emergency room at that time, the percentage of patients receiving care within less than 90 minutes was 83%. And you can see the median door-to-balloon times is significantly lower when that process is activated prior to patient arrival. And importantly, among this observational study of these patients, the in-hospital mortality rate was significantly lower in those patients who had pre-hospital activation. 3% mortality versus 5.5% in those who presented themselves to the ED. And this observational study enhanced our enthusiasm and encouragement that pre-hospital activation is a very important part of the process to reduce mortality. And this was a relatively small population, so we reviewed our data in a larger population, shown here in these bar graphs, from 2007 through 2014. And you'll see on the graph to the left-hand side of your slide, among 1,200 or so patients who presented to the ED, the door-to-balloon times were in the range of 77 minutes, with a mortality rate among this population of 6%. But in contrast, for those who had pre-hospital activation in a sizable population of 750 patients, the median door-to-balloon times were around 40 to 45 minutes, and the mortality rate was in the range of 4%, significantly lower. Again, supporting this idea that pre-hospital activation is very important in reducing mortality. You can see in the graph to the right the times to treatment and mortality among those that are transferred from another distant hospital. Of course, their time from presentation to balloon intervention for angioplasty is significantly higher, and their mortality rates are also a little bit increased. For each EMS provider to play an important role, you have to learn how to recognize this syndrome, both based on its clinical features as well as the EKG features. And today, the remainder of this discussion will be focused on how to use the EKG, how to recognize the pattern of ST elevation. And just for a simple review, based on the American College of Cardiology, American Heart Association's definition of what is ST elevation MI, it's important to appreciate that it is a clinical syndrome, and it includes the symptoms of the disorder as well as the EKG markers. So it's very important to learn the characteristic symptoms, which include chest distress as the classic symptom, but other symptoms may occur, including unexpected sudden onset of shortness of breath or syncope, passing out. Nausea, vomiting is an unusual presentation. but can occur. And importantly, as you probably know from your experience, the symptom doesn't necessarily have to occur in the chest. It can occur in the upper neck, the jaw, the shoulder, the arm, and sometimes in the back. It is the acute onset and unexplained nature of the symptom that is the hallmark of the clinical symptom. And of course, then there is the EKG pattern. To appreciate the ST segment changes, let's first review basics. So first, it's important that you learn to recognize what is the ST segment and what is the J point. Here you see a schematic diagram of an EKG. The J point is the end of the QRS complex with the arrow, and the ST segment is that portion of the EKG pattern that is between the J point and the beginning of the T wave. Important to appreciate that after the P wave, there's a isoelectric line. Isoelectric meaning there's no change in electrical current above or below. And also after the T wave and before the subsequent P wave is the isoelectric line. And the level of the ST segment relative to the PR segment or the so-called TP segment is very important in trying to understand what is ST segment elevation. So here's an example of a patient's EKG against schematic drawing of J point elevation above the isoelectric line and ST segment elevation above the isoelectric line. These are other schematic drawings showing a patient who has ST elevation above the isoelectric line. This is in contrast to the so-called non-STEMI patients who may have ST segment depression or no ST segment depression, but just T-wave inversion. These latter two schematic examples of non-ST elevation MI have to be distinguished from the ST elevation, which is above the isoelectric line. Bring your attention to this EKG and study it carefully. This is a patient with acute severe chest pain. This is his first 12-lead EKG. You'll see that he's in sinus rhythm. And if you focus on leads 2, 3, and AVF, you'll appreciate that the J point is above the isoelectric line, defined as the TP segment or the PR segment. And the ST segment is elevated as well. And there's a significant elevation reflecting injury current. And this is the EKG pattern of a patient who likely has an acute coronary artery occlusion. When this patient came to the cath lab, the right coronary artery was completely occluded. And this EKG pattern is the hallmark of acute inferior wall ST elevation myocardial infarction, typically due to right coronary artery occlusion. Fortunately for the patient, we were able to restore flow, and you can see the features of the contrast material flowing through the normalized repaired right coronary artery after balloon repair and stenting. This is another patient who presented with acute chest pain syndrome, and this is their first 12-lead EKG. Studying the EKG, you can appreciate that they have a sinus rhythm. The QRS complex is relatively narrow. Importantly, if you bring your attention to leads V1, V2, and V3, you'll see that the J points are elevated above the isoelectric line. And you'll see that the ST segment is elevated above the isoelectric line. You can quantify the degree of ST segment elevation in millimeters, representing the magnitude of the J point elevation. It's important when you're quantifying ST elevation that you quantify it at the J point. So perhaps best and easily as seen in V2, there's approximately a 2.5, maybe 3 millimeter J point elevation, and in V3 there's approximately a 2 to 3 millimeter J point elevation. This patient who comes to the cath lab was observed to have a critical obstruction in the left anterior descending artery seen on the coronary angiogram here. So this EKG pattern was the correlate of this patient's critical acute coronary syndrome with ST segment elevation myocardial infarction due to occlusion of the left anterior descending artery. Let's consider this patient. This is a 47-year-old male with acute chest pain, and he has 2 millimeter J-point elevations in V2 and V1, and the ST segments are elevated. That's the segment after the J-point before the T-wave. The question is this degree of ST elevation significant? So if you were to see this type of pattern in the field when you do your 12-lead EKG after you analyze the patient's symptoms, and you ask yourself, is this a cardiac emergency? Does the patient have ST elevation MI? Although the findings are relatively subtle and the magnitude of the J-point is very minimal, you could elect to say, yes, I'm activating the emergency process. And if you had done so when the patient comes to the lab, what we actually saw in this patient was complete occlusion of the left anterior descending artery. And the point of sharing this with you is that you don't always have very dramatic J-points or J-point elevations that are above some minimal number. They sometimes can be very minimal. Now the problem is, of course, is that there are many patients that have minimal J-point elevations who don't have coronary occlusions. Let's consider this patient. Oh, by the way, this is the angiogram of that patient. When they first arrived, the LAD was 100% occluded. After angioplasty, flow was restored through the left anterior descending artery. You can see contrast flowing all the way down to the distal end of the vessel, reflecting a good result by the interventional cardiologist who was able to restore flow. But let's consider this patient, 37-year-old male, acute chest pain. This is the first 12-lead EKG. And if you focus on leads V1, V2, and V3, you'll see the J-points are elevated, the ST segments are elevated, and it certainly is suspicious for an acute ST elevation myocardial infarction. And it would be reasonable to activate the MI alert process prior to hospital arrival. However, this patient had no coronary artery disease. It's important to appreciate that you cannot make a definitive diagnosis of acute coronary occlusion based on one EKG. You can only suspect the presence of coronary occlusion, and the suspicion, of course, is linked to the symptom complex. But even among patients with symptoms suggesting an acute coronary syndrome, they may have an EKG pattern like this, which is not due to coronary occlusion. This generates questions and concerns about how accurate are we in predicting this true cardiac emergency. This is a publication that reflects how approximately 6% of the time skilled ED physicians call it wrong. They think that there's an acute ST elevation MI, the patient goes to the lab, and there's no coronary occlusion. This commonly happens in patients that have had an old myocardial infarction and they're left with a left ventricular aneurysm. It can happen in people that have this pattern referred to as early repolarization. Patients with pericarditis or left ventricular hypertrophy can also have J-point and ST elevations not due to coronary occlusion. Now, if you had an old EKG for comparison and you documented that the ST elevations were unchanged, it would support the idea that this is not an acute coronary syndrome and lead to the decision to not activate the MI alert process prior to patient arrival. In an effort to minimize false calls or so-called false positive activations of the MI alert process, the American College of Cardiology, the American Heart Association gathered experts together. They considered the recommendations from the World Heart Federation task force that published the universal definition of myocardial infarction and published their recommendations on what EKG criteria we should use to help activate emergency processes of care. And as with any criteria that are chosen, they are advised in an effort to maximize both the sensitivity of accurately detecting the problem as well as the specificity. This is from the publication in 2013. The publication states, in the absence of left ventricular hypertrophy or left bundle branch block patterns, new ST elevation at the J point in at least 2 continuous leads greater than or equal to 2 millimeters in men, or greater than or equal to 1.5 millimeters in women in leads V2 and V3 were indicative of probable acute coronary occlusion. They also proposed that ST elevations greater than or equal to 1 millimeter in any other contiguous chest leads or contiguous limb leads was indicative of probable coronary occlusion, and proposed that this could be criteria used to maximize sensitivity and specificity in detecting an acute coronary occlusion and minimizing false calls where we activate a process of care and observe that the patient has normal coronary vessels. Our own hospital's committee of cardiologists, ER physicians, internists, nurses, pharmacy people, administrators, communicators who periodically meet to review our process of care, proposed an alternative to the ACC/AHA guidelines that we thought would be simpler to use and would maximize specificity, that is, the accurate detection of an acute coronary occlusion, and would be valuable to emergency medical service personnel. And the criteria that we proposed are documented here. One is chest pain or any other symptoms suggesting an acute coronary syndrome within the past 12 hours. Second, an EKG showing a narrow QRS complex. That is to say, patients with left bundle branch blocks and right bundle branch blocks were excluded. So those with a narrow QRS complex plus greater or equal 2 millimeter ST segment elevation at the J point in V2 and V3, and or greater than 1 millimeter in 2 other contiguous chest or limb leads would be appropriate criteria for activating the pre-hospital MI alert process. Now note that this is distinguished from the ACC/AHA criteria, which had different variables based on gender. To simplify, we advised using 2 millimeters for both men and women. Also important was the age characteristic less than 85. The patient also needed to be medically stable, which we defined in part as systolic blood pressure greater than 90 and a heart rate that was not too fast, that is less than 120, and not too slow, greater than 50. And importantly, the patient could have no exclusion criteria for participating in the process, exclusion criteria including the patient doesn't wish to undergo the process, or the patient has an end-stage disease process such as malignant cancer or a wish for no aggressive care. Exclusions that would lead to the decision to not activate the MI alert process until further evaluation in the emergency room. Let's consider this patient whose EKG is now in front of you. This is a 68-year-old male with chest pain suggesting an acute coronary syndrome. He had a history of diabetes and hypertension. And as you can determine from careful study of this EKG, the patient has a sinus tachycardia. If you look in lead V1, you'll see the P and QRS complexes. The QRS complexes are wide. And as stated before, this pattern would not be considered eligible for pre-hospital activation by EMS. Nevertheless, it's still reasonable for you as the EMS providers to consider discussing your concern with the team that you're contacting in the emergency room. And you could describe your clinical assessment. This patient has an acute chest pain syndrome suggesting an acute coronary syndrome. They have sinus tachycardia with a wide complex rhythm. The pattern suggests left bundle branch block, and you can say, I'm concerned this could be a myocardial infarction. Our current systems program requires that this EKG be evaluated by the ED physician and or the interventionalist on call before activating the system. Now, why is that important? In the ACC/AHA guidelines in 2013, they removed the recommendation that new or presumed new left bundle branch block should be treated as an ST elevation MI. And the reason they took this out was because this pattern, left bundle branch block, is often associated with a false positive. That is to say, everyone thinks there's a coronary syndrome with a coronary occlusion, there's an emergency process, and in the cath lab we observe no coronary occlusion. And this happens anywhere from 50 to 85% of the time. It's very common for this to happen. And so left bundle branch block as an EKG pattern was removed from the ACC/AHA guidelines for a reasonable pattern to activate an emergency process of care. As you can imagine, from a hospital network's point of view, that when we activate this process unnecessarily, it increases the cost of care, it may not improve the patient outcome, and it certainly puts the patient at risk unnecessarily. Now, what's important to appreciate is that the ACC guidelines made reference to the option to consider the Scarboza EKG algorithm. They did not specifically recommend using this algorithm. However, our program believes that the algorithm is valuable, and I'll share with you some of the principles of this algorithm, which is somewhat complex, so that you understand the concept. Keep in mind, however, that in patients with bundle branch block patterns, we recommend that the patient be transported to the emergency room, at which time the EKG pattern can be further evaluated with the option to activate the MI alert process if the patient has the characteristic Scarboza criteria, which are designed to enhance sensitivity and specificity. So these are the so-called modified Scarboza criteria that are used when analyzing a patient with left bundle branch block. If any one of these variables is present, it's reason enough to activate the MI alert process. The first variable is ST segment elevation greater than 1 millimeter, concordant with the QRS complex in any lead. The second variable is ST segment depression greater than 1 millimeter in leads V1, V2, or V3. And the third criteria is ST elevation or depression greater than 25% of the QRS wave amplitude in any lead when the ST segment shift is discordant with the QRS complex. Now, these phrases of concordant and discordant are potentially confusing, and to help you understand them, let's consider these schematic diagrams. So you'll see two EKG schematic drawings of concordant ST segment changes. So let's consider this pattern, P wave, wide QRS reflecting the left bundle branch block. You'll note that the J point is elevated, the ST segment is elevated, and it moves in the same direction as the QRS complex. That is to say, it's concordant with the QRS complex. And in this case, the magnitude of elevation is 2 millimeters. This would meet one of the modified Scarboza criteria. You'll see the point assignment, which was originally used in the original Scarboza criteria. And the more points you had, the more likely you were to have a coronary occlusion. In general, more than 3 points was associated with coronary occlusion. So this type of pattern was highly specific for detecting coronary artery occlusion. This is another example in the middle of a concordant ST segment shift. In this case, the QRS complex is negative. It is below the isoelectric line, which is here. And the ST segment shifts in the same direction as the negative QRS. That is, it's shifting negative or down below the isoelectric line. It is concordant with the direction of the QRS. And the magnitude of this J-point depression is approximately 2 millimeters. And this is yet another one of the criteria of the modified Scarboza criteria, particularly if it's seen in leads V1, 2, 3. Now the pattern all the way to the right of the screen is an example of discordance. So you'll see the P wave, the QRS complex, the J point and ST segment are elevated, moving in the opposite direction of the negatively directed QRS complex, that is to say, in a discordant way. And when the magnitude of the J point elevation is greater than 25% of the QRS amplitude, that's considered a correlate of coronary artery occlusion and is highly specific for such a pattern. So these are examples of this Scarboza phenomenon. These are some more examples of the modified Scarboza criteria. In this case, there's discordance between the uprising QRS and the depressed J-point and ST segment, and the magnitude of that depression is 40%. And in sample B, another example of discordance, negative QRS, ST segment, J-point are above the isoelectric line in the opposite direction, that is discordant of the QRS, and the magnitude of the J-point elevation in this case is 30%. Both of these are examples of shifts that are greater than 25%, reflecting a high probability of significant obstructive coronary lesions at the time of coronary angiography. These are some 12-lead EKGs demonstrating these patterns. You'll see in A, a wide QRS complex, and in lead V3 at the arrow you can see the J-point is elevated significantly above the isoelectric line, and it's discordant with the QRS complex, and the magnitude of elevation is more than 25%, indicating a high likelihood of coronary occlusion. In V5 and V6 you see J-point elevations that are concordant and greater than 1 millimeter, again reflecting significant coronary occlusions. In B, you'll see the example in V2, V3 of J-point depression and ST segment depression, concordant with the QRS complex. It's analogous to this schematic example that I had showed you before. Here's yet another patient with chest pain and a sinus rhythm, wide QRS, left bundle branch block pattern, and you can see in lead AVF there's significant J-point depressions, ST segment depressions, discordant with the QRS complex. The magnitude of this depression is 25% or more of the QRS complex, and therefore it's significant, highly likely that this patient has acute coronary occlusion. You can see other examples of discordance here in AVL and in V2, where the very big negative QRS complex and a very high J-point. What was published by Dr. Smith in Annals of Emergency Medicine in 2012 was their analysis of these modified Scarboza criteria, documenting very high sensitivity and specificity, 90% or so, for identifying coronary occlusion. And our current process of care involves using this criteria to help us accurately observe and document coronary occlusions and appropriately activate the MI alert process when a person has any one of these modified Scarboza criteria. So to summarize, the criteria for pre-hospital activation is designed to help us work together as a team to rapidly identify patients that are highly likely to have a significant coronary obstruction and who would benefit from timely reperfusion therapy, to minimize their risk of death as a complication of the acute myocardial infarction. The process is designed to minimize false activations, false positive EKG interpretations, and the associated cost of that process of emergency coronary angiography. We encourage that the EMS providers use the so-called NEAR, N-E-A-R, NEAR concept, standing for narrow QRS complex, elevations in the ST segments, angina-associated type chest pain, and a heart rate less than 150, as a way to remember the key features of when to consider pre-hospital activation. The N in the NEAR stands for a narrow QRS complex. We do not advise that you activate the process in patients with wide complexes such as left bundle branch block. We recommend that the ED physician be responsible, either alone or with the help of an interventional cardiologist, make the interpretation to identify the modified Scarboza criteria. But on the other hand, if you do see a narrow QRS complex and there's greater or equal to 2 millimeter ST elevation at the J-point in V2 and V3, or you see greater or equal to 1 millimeter in any other two contiguous leads, including the chest leads as well as the so-called limb leads, that is criteria for pre-hospital activation. And of course you would only do that if the patient has angina-like symptoms and they don't have any exclusion criteria such as heart rates that are very, very fast. It's important that you know that every one of our cases are reviewed. The complexity of the process of care involves effective communications, teamwork, and reevaluation after every case so that we learn how to improve the process of care, improve our patients' outcomes, and minimize the potential for death. You are our partners. We need your help with this, and learning how to interpret the EKG is a very critical part of what you do. I hope this information has been valuable to you in recognizing ST elevation MI and learning when to activate the acute MI alert process. Thank you for your attention.